Hi, good morning, everyone. Today I have the pleasure of being here with Dr. Georgios Kakavas. He is a top LinkedIn voice, and he's a physical therapist. He's an athletic trainer, a scientist in neuroscience. He's a speaker, serial entrepreneur, author, startup founder, and he's doing a whole bunch of different things in Greece and all over the world. And I have the pleasure of having him today. Dr. Kakavas, how are you doing today?
I'm fine, Oscar. Hello.
Hello,
I'm
hello.
fine.
Um, thank you very much. So, um, for those of you that, for the people that don't know you, they don't know who you are. Who are you, and what are you doing, in Greece? Like, what are you working on?
Yeah. I'm a physical therapist and also a researcher. I'm a speaker, mostly at sports medicine events like isokinetic FIFA events, ECOSEP, uh, and I will be at the biggest orthopedic congress this year, the ESCA Congress. This is the biggest orthopedic event at the I will be a chair for sports medicine session there because we're running with ESCA and AOS. AOS is the American ESCA. So it's like the Association of American Surgeons and Sports Medicine Doctors. So we're running a big consensus regarding ACL injury prevention. So we will show the results on Prague. This is May, 20th of May. And I'm involved in project in Greece and abroad. It's very interesting. I was an athletic trainer and I become a physical therapist. Okay, so I started my master degree in sports rehabilitation. Then last year, I achieved my PhD on sports injury neuroscience. So this is my topic, and the invitations around the globe. Yesterday, I spoke on the Tokyo University conference about the brain-knee connection. Is very interesting, and all the research we run is what is happening, the connection of the nervous system and the joints, the spine, and also the orthobiologics. They have a nervous system connections.
Of course. Wow. So you have your work in different aspects. And I did yeah, I did some research on you, obviously, and on your LinkedIn. It also says that you are in like space, in the space. What, tell us a little bit about that.
Yeah, we have, okay, right.
Yeah.
Well, we have created the big problem on the COVID era. So we lost our patients. So the question was, where are they patients? Okay,
What do you mean by you lost the patients? What do you mean by that?
they stopped the treatment because we have a lockout in Greece and Europe. So in one day, on this month, we lost 90% of our patients in one day.
Because
Okay,
of COVID.
so because of the lockout. So
Yeah.
I have
That was
plenty of
worldwide.
time. Huh?
That was worldwide.
Yeah, I agree with you. But the state, they keep our clinics open because we must serve and rehab patients with maybe broken leg, patients after surgeries. So, but the patients, they disappeared in one day. Okay. So I had a lot of time to start to think, okay, how can I approach those patients? So we built a platform, software as a medical device platform, to monitoring orthopedic patients when they're away from the clinic.
Okay. Is
Okay.
that a wearable?
Is this this is a combination of a wearable and a platform. Software as a medical device platform. So I'm involved in space applications with the European Space Agency. And they like the idea to use the platform for the astronauts. Okay?
Wow.
So, yeah. So we will run some tests on here. The European Space Agency Center is in Germany. So we want to know what is happening in people when they're in microgravity.
Interesting.
But you know, the same thing is when I have a person around 65 years old with an knee osteoarthritis, after an orthobiologics procedure, they're laying down. This is microgravity again.
Yeah, you're
So
right.
we have a phenomenon which is neurological, the phenomenon of arthrogenic muscle inhibition on the joint. So you cannot activate your quad. But it's not about force. It's not about, you don't have pain. You don't have a fusion or edema on your knee, but you cannot activate it. The brain, it's like a break from the brain. Stop use it. That's why all this work is connected together. Microgravity, people with sarcopenia, AMI, all these is like a chain of events. Okay? Is this complicated for you? But why? Because the astronauts, they are on microgravity. So in Cologne, they have a facility with a treadmill which is vertical, not like this. Okay?
So not
So,
weight bearing.
yeah. So if you walking or running on the vertical one, the microgravity is there. Okay? The gravity is less. So we will do with the platform and the wearable some tests on astronauts there. It's a very interesting concept.
Interesting. And by you being vertical, by the patient or the subject being vertical, does the weight bearing shift to other parts of the body?
No,
No?
you have. It's like you walking on the moon because the microgravity with the moon. The big problem, if you remember the old NASA videos, they don't walk, they jump. So the idea behind the microgravity treadmill, the vertical, is to learn to walk.
Yeah. On the
Eh?
moon.
Yeah. But what is happening on your spine with the microgravity? You have problems with the discs. Okay. What is happening with your joints? Knee joint, hip joint. You have problems from the microgravity. The human body needs gravity.
Yeah.
We will see afterwards if you have a tendon with after orthobiologics, you need load. If you unload it, you have problems, big problems. Okay,
You
we
load it.
have
Okay.
problems with tendinopathy and other things.
Yeah. Okay. Well, so yeah, you're going to have to share with me that work so I can put it on the description so people can keep up with that because that seems very
Yeah,
interesting.
it's I it's not good to share everything on LinkedIn. Okay, because some projects they are upcoming or but we have signed with a space analog. Space analogs, they every NASA and ESA they using space analogs. Space analogs means a space analogs is in Antarctica. Why in Antarctica? Because the weather on Antarctica it's like the weather on Mars. So
I did
they
not know that.
running, yeah, they running tests, ergophysiology tests on this environment, which is not good, a negative one or a hard one, because they want to see the adaptation of the astronauts to this environment.
Interesting.
That means this is a space analog on Antarctica, space analog on Austria, on UK, every country, and I think every state in US, they have a space analog. They running research projects for NASA and ESA. Okay? So
Wow.
that's why I'm involved on this.
Amazing. Wow. Okay. We're going to have to do another podcast in the future with updates.
Yeah, of course. If we have results from our research, of course we can.
Yeah, beautiful. Okay. So the title of the podcast of our conversation is From Injection to Outcome. Okay. Periodizing rehab after orthobiologics. What does that mean to you?
This is Oscar. This is our last paper. Okay, it's published before now on March on GCM. Why? Because I have seen I'm in the orthobiologic rehabilitation since the start. So I'm a member of ARMOS. The ARMOS is the Orthopedic Society for Orthobiologics. Okay?
Where are they headquartered? Where are they from?
I think the president is Turk from Turkey. Okay? But now they had in Tokyo their last session. Okay? So I'm like a member of the Rehab committee there. And the idea is why we have different results with patients from the same cohort. Cohort means I have a patient with the same BMI, with the same age, with the same procedure, and the one patient goes very well, and the other patient no. What's the difference? The difference is on rehabilitation. And in some patients, because I insist on that, is on pre-rehabilitation. They don't do prehab to make the joint ready for the orthobiologics procedure. So they don't do that. Okay? So the periodization, as you know, is a fitness trend, but it comes from Greece. Do you know that?
No, I did not know that.
Yeah. So periodization comes from Greece. Why? Because we had an Olympian athlete, and the idea he was the father of periodization. Why? Because before the games, he carries a small cow and walks for a kilometer. Okay. When the cow grows, he make the same kilometer with a heavier cow, the same cow but heavier. Can you understand?
Yes.
He created the first plan, and then he created the first periodization plan because he made the plan according to weight I must lift, for how much time, and this has happened 2.5 thousand years before.
Okay.
So I'm from the first people, I think, if you see the research, I applied the periodization rehabilitation. Why? Because when I have a rehab which is longer, okay, like ACL, or after an Achilles tendon surgery, so I need a rehab plan for 6 months, 7 months, 9 months, okay? Sometimes if you are an NBA player, maybe 12 months. But so this thing must have a plan. This is periodization and does not go with timing.
Okay.
So till now, what is happening? You make an arthroplasty or ACL, or you make an orthobiologic procedure and you take a paper with different things. You do this in first week. You do this in third week. You do this in 5th week and coming on 6th week for a check. Okay? But some patients go faster. Why to
Yeah.
wait? Huh?
Yeah. Yeah. I agree.
And the idea is from 0 to 6 week, I don't have any data for this patient. So
Okay.
I'm doing a very expensive procedure like surgery or orthobiologic treatment. And for 6 week, nothing, no data. That's why I created the platform. The platform gives information to the surgeon or to the physical therapist from day one. So I'm getting in my dashboard and I can see what is happening with Oscar, what is happening with the subjective data, which they're coming from PROMS. Do you know what PROMS is?
No.
PROMS is in medicine the questionnaires. So we have questionnaires for every condition. We have questionnaires for knee, for hip, for low back. Okay. So all the organization and clinics and hospitals, they use questionnaires to assess subjective data of the patient. Okay. And I have the objective data from my platform and the wearables. So I have a constant monitoring when the patient is post orthobiologic or post surgery. Okay, this is the
Interesting.
whole idea.
No, that makes total sense. So, when we first started talking, to be honest, I did not know what periodizing meant. So I had to look it up, right? Because I was like, wait, I had to look it up. And the definition, it says divide a portion of time into periods, right? So now that you explained it, it
And the
makes
load, Oscar, and the load.
okay.
So you take loads according to time and periods for the goals you want to achieve.
Gotcha.
Huh?
Okay. So
Or maybe in the beginning I have low loads on your knee, but if you are without symptoms, your knee is pain free, the range of motion is good, why to wait for 6 weeks to load your knee more?
hmm,
If you
interesting.
pass, if you pass all good, all the guidelines are good, or or the factors, so I can load your knee faster without any danger, right?
Yes. I mean, if the patient is ready and obviously but that's a great approach. And that's more of a personalized approach. I mean, I don't know how it is in Greece and in other parts in the world. And I'm not speaking for almost every physical therapist. I'm sure there's a good amount of person of PTs, right? That do a great job. But however, my son ended up getting he used to walk on his toes, and I would always tell him, don't walk on your toes. But it got to a point to where his Achilles and all that was too tight. He couldn't
Yeah.
bend, he couldn't touch his toes, so he ended up getting a little minor surgery. They did a little incision, and I think they just released that tendon to
Mhm.
where
Release the tension. Yeah.
yeah, correct. And I remember that I was taking him to physical therapy. And to be very honest with you, they were not doing a good job. Because I come from a, personal training background. I went to school for exercise physiology. So I took the anatomy. I was a personal trainer throughout my college years. And so, like, I was giving him, a
Like
plan. I'm like,
instructions. You gave
yeah,
him
like
instructions.
instructions, do this, stretching him
Yeah.
out because I thought that they were
Oscar,
doing a good job.
I have been in US many times,
Yeah.
and I think the curriculum on the physical therapy universities or colleges is outdated. Why?
It's sad to say
Why?
it. I agree.
Yeah, because in Europe and the rest of the world, like Australia, because Australia, they have a very good physical therapy there, and sports science. Uh, uh, now they think the borders between rehabilitation and fitness and performance, they does not exist. When you get rehabilitation and when you get out to performance. So somewhere the borders are like that. Or you must do a lot of performance things in an early stage. So the issue is the early years of orthopedics and physical therapy without the load is bad. That's why I have many patients at rest. Get some rest.
Yeah.
And then the sarcopenia came out because, you know, the sarcopenia is like, it's like, it's something that does not need medicines or and the big pharma is not interesting about that. It's not like the bone density in women. Okay, and the osteoporosis, they have a lot of drugs made for this. But for sarcopenia means I'm losing muscle strength and volume because of offloading.
Mm,
Or
interesting.
the idea is after 45 to 50 years old, I'm losing normally muscles. So the whole theory the years before was get some rest.
Yes.
I have a low back pain. Get some rest. But all those pathologies, and of course the pathologies connected with orthobiologic, they need load, but the load needs periodization. That means you must have a plan when.
Yeah. Yeah.
And the when is the big question. Why? Because I have three principles. How old are you?
I am 35.
No, not you, the patient, okay? Second principle. How serious is your pathology? Is okay? Is a like I have a problem with arthrosis 4 stages, or maybe it says first stage. Okay, and the third one is how much time I have this condition.
Okay. How long you've had it for?
Yeah, how long you had it. So according to this, you must make a good decision making about loading the joint, loading, you know, the muscle, loading the tendon, loading the ligament, whatever it needs. Okay. And that means you must have information from the other side, from the performance, from the fitness side, because they work a lot with load, with athletes. But I think the people out there, they are everyday athletes, because some people, they want only to be healthy, to go to the supermarket without pain, to go an excursion, to go for a trip somewhere, to go to a mountain to walk,
And with their kids, with their grandkids.
whatever, to play with the grandkids. Okay, so this needs strength. Okay, because we live in gravity. So gravity affects our joints, tendons. You see how the things are connected,
Yeah. Yeah. Okay. And earlier in our conversation, you mentioned that prehab is very important, and patients or physicians or PTs, they do not focus on the prehab. What does prehab mean to you, and what do you mean by prehab? What does that mean?
Okay, what means prehab? So I have a knee with a grade 3 arthrosis. Okay, that means I have a knee without range of motion. I have a knee which is painful, hot, and with a lot of edema. Okay, and of course weak. The quad and the hamstrings are very weak. Okay, because as we said before, the pain and the fusion creates arthrogenic muscle inhibition. So I cannot doing my everyday things. If I'm starting a prehab, that means before I'm doing the orthobiologics treatment or the arthroplasty, okay? If I'm preparing the knee, so not to have a fusion, some exercises for the range of motion, to make a treatment for pain, to explain to my patient what pain is. This is a big question because on the curriculum, we don't have education about pain neuroscience. We have many forms of pain. It's not one. So this is a different podcast, okay? I must explain to my patient what is happening because maybe I have pain, but I don't have tissue damage. This is an easy one, okay? Maybe I have a pain with a tissue damage. I have a damage on cartilage, okay? If Oscar, I make a prehab to prepare the joint for orthobiologics, the post orthobiologics or surgery rehab will be shorter, right?
Yeah. Yes. Yeah.
The
Got it. So
patient will be more optimistic
yeah,
because
it's true.
when you inject something in the knee, for example, the first days we have an inflammation and a reaction of inflammation. This is normal. You must explain to him, okay? We have a reaction from this procedure. This is not a bad thing. But if the knee was prepared with prehab, the patient knows, gets better, and the rehabilitation gets shorter. So the payers, like insurance, they pay less. So all the system is better.
Interesting. Yeah.
Okay?
Yeah. Thank you for explaining that. It makes sense. So I recently did a podcast this week with there's a doctor here in the United States. He's located outside of Houston. His name is Dr. Robert Talek. And he's a spine surgeon. He's a scientist as well. And he gave a great analogy that he said that most of the time is not the injection. We focus on the product and the injection. But it's like he gave a good analogy of it's like when you're going to plant a seed, right? You're just not going to put the seed in a soil that is bad, right? And so essentially make sure that the soil has all the nutrients. It's, I'm not
With no
a
water,
planter, right?
no sun,
Correct.
you know?
Correct. So you
It's
want to,
it's the same thing. I agree
yeah,
totally with him. It's the
yeah,
same thing because, now we have the experience and the orthobiologics, we have different options, like a bone marrow or a PRP or whatever. We have many options
so
now.
many.
Yeah. We have, okay, a lot of RCTs. RCTs are randomized control trial to compare the results, but they don't then don't rely the results because the patients, they take an injection, they go home, but you don't know how many steps he makes every day. Does his home have stairs and how many? No information.
Dr. Kakavas, 100%. You know that I this year I've taken upon myself to do more podcasts with scientists and doctors. And I believe that everyone that I have spoken to has said the same exact thing about RCT trials are not optimal to tell us real world data. They lack from what your point of view, what you mentioned, to like it's not the same to where when a doctor talks to the patient, brings them into their own practice, nurtures them, follows them through versus just a test, right? Like a
Yeah.
trial, right? It's not the same.
The idea is, I don't know if I can send that. said that. The idea is that the orthobiologics was a new tool for orthopedic surgeons and neurosurgeons in some cases. So it was a new tool because before that, they did analgesic injections to patients, okay? Maybe with steroids, okay?
They still use that
Whatever.
widely today.
No, but it was, the first thing, let's make an injection for pain, okay? Totally pain, okay? Totally pain. Then the orthobiologics came in and say, okay, we have a new tool here, but this new tool, it's not getting in a protocol. As I told you, the protocol means I have to measure before. So maybe I have a patient which is 7 to 10. Like the patients, they are starting their treatment from different
level stages.
If I have a patient with pain 9 to 10, it's totally different because this patient has kinesiophobia. Do you know what kinesiophobia is? Kinesiophobia means I don't want to use my leg because I'm in pain. Kinesiophobia is a Greek word, okay? So that maybe the patient is lazy because of his pain. He has, as we told, sarcopenia because he's 70 years old. So we don't have any protocol to make cohorts of patients. Cohort means this patient has the same quality
characteristics, maybe?
Yeah, characteristics. So and the same applies to the rehabilitation afterwards, okay? Not all the patients have the same results from orthobiologics.
Interesting. Yeah.
So you must start the rehabilitation from different levels. That's why we need a plan. So the periodization is a plan for rehabilitation. If I don't have a plan, I'm
Outcomes are
not
not going to
doing
be good.
nothing. That's why I told you about the curriculum and must the two sciences, the physical therapy and the performance sports science, to get more together, and the one and the other to get knowledge and information about not only pathologies and performance.
I
Because
agree.
I have many athletes which they're underachievers because they carry a small injury like a
Right.
chronic condition. So I cannot activate my muscles. I have kinesiophobia. I cannot do very fast changes of direction. So you see, everything comes in place here.
Yeah.
So we need a plan before and after orthobiologics, and not only, okay, come to my office, it's very easy, let's make a PRP. Okay?
Interesting. The title of that podcast that I did with the previous doctor that I was telling you is that it was about that regenerative medicine doesn't have a product problem; it has a thinking problem. And
Yeah.
so I think that
Totally.
that ties.
I agree with you totally, because the last 10, 15 years, they created great products. Okay? So in the beginning, they had problems with adipose fat tissue.
Okay.
Okay? How can I transform adipose fat tissue to cartilage? Okay, this is a question, okay? Because you have a different tissue.
Yeah. Okay.
So, but now the biotechnology creates very good products, but they lack of protocols. So to say, I have a cohort of patients with these characteristics, and I think the PRP is better for them.
Yeah.
Or I have a cohort of patients with these characteristics. Maybe this is a quality characteristics. This is about pain. This is about range of motion, strength. Maybe the bone marrow is better for them.
Yeah.
So you see, they focus on the procedure because it's like a magic, you get my blood, you uh, uh,
Spin it.
go to the machine, yeah, and you see magic, okay? And that's why many patients, they are frustrated because the outcomes, they're not good. And this is not good for the profession, for medicine, for the community,
For
because
everyone.
they cannot control the results, the outcomes.
Yeah. Yeah. Because they're not prepping the soil either, biologically or mechanically, right? In a way.
And to see what is happening after I did it, after I put the seed, what is happening there? Does this seed is hydrated? What is happening with the weather conditions? So that's why I told you about the lack. They have a lack of monitoring, and this happens if you do an orthobiologic treatment or if you do an arthroplasty.
Interesting.
They don't have uh, uh, how to measure the outcomes of this patient in every quality characteristics they need. So quality means my wellness and my quality of life is increased. I'm feeling better.
Yes.
I can walk. I can play with my kids. Okay. That's why I told you we need the questionnaires. The questionnaires, they answer that.
Yeah. Yeah.
And the the platforms, the software as a medical device platforms, because this is, do you know the term SaaS? SaaS is
Software as a service.
software as a service.
Yeah. Yeah.
So
Yeah.
it's the software as a medical device is a software that can change the doctor prescription. If that's why we're using lights, we're using red light, stop exercising,
Yeah.
danger, or yellow light, or green light, everything goes well. We don't have that. In the surgical industry, now they have very good platforms to make pre-surgical planning. What means that? If I'm doing something on the knee, and do you know what robotic surgery is?
Yes, I've heard of it, but please explain.
Yes.
Just search
So
robots doing
they're
surgery.
using, yeah, they don't using straight tools, but they one robot make all the pre-surgical planning, how many degrees I must. So when the insertion of the ACL will be for better, if I have a pediatric ACL, I have to watch where on the cartilage must put the graft, because I will have problems when this kid goes elderly. Why? Why? Because all these things we need to plan it. That's why I'm talking about plan, plan, plan. You must plan it. So they are planning good with the surgery, but they don't have plan post surgery.
Yeah. I agree with you. And I think planning, having a roadmap, a direction of where you're going is vital for anything, right? For personal, for a business. You need to have a plan because if you don't have a plan, where are you gonna
Every,
go?
that's why I'm talking. It's very strange. That's why I told you it's very strange. They don't have post-surgery monitoring. They don't have post-orthobiologic monitoring.
Yeah.
It's very
Yeah.
strange, because, okay, what is happening next? Because sometimes, the patient calls back and say, I'm not okay. What means that? What means that? Nothing. Okay, I'm not okay.
I was going to say you need
Hey,
more. Yeah, what do you mean by that?
yeah, well, it's many things. I'm not okay.
Yeah.
Maybe I don't have extension 0 in my knee. That means I cannot walk. Hmm? That's why I told you the plan. It's very easy if you have or a prehab plan or a good post orthobiologic rehab plan. Okay, I think everything it goes better. The people they will achieve a better quality of life, and of course we will help athletes to become more efficient, to become faster to heal.
Yeah, amazing. Yeah. So you've developed a phased approach that we've been kind of, we've been talking about it this whole conversation. And the approach that you've developed is essentially protect, rebuild, recondition, return. Can you walk us briefly through each of those phases and what are the
Yeah,
goals of that stage? So
the goal,
protect,
the goal,
rebuild,
the goal.
recondition, return.
Yeah, you know, before the new we had uh, an acronym named RISE. Do you know the RISE?
Yes, actually, I learned that in
Do you
in
remember?
school. Rest,
Yeah,
ice, compress, or something like that, and then
elevate, elevate.
elevate.
Okay, so this is outdated.
I remember that, learning that.
So now we have a new approach. The name is peace and love. That means this tissue, which is uh, in the first days after orthobiological, is very tender tissue. Okay, it's a painful tissue. On inflammation, I must protect the biology of the tissue. This is the protect. Okay,
So, okay.
then if I achieve the milestones, what means milestones? I have a no pain, or I have 2 to 10 on the scale pain. I have less edema, less effusion on the joint. All the other joints are functional. So, because when something happens on the knee, the brain, we have a brain map here. So the brain map is affected. So I'm activating different parts of the brain to do the same thing. Okay? So that means the brain activates a lot the ankle and the hip to protect the knee.
Okay, so it's overcompensating for the knee.
Yes, compensation because it feels threat. The threat comes. That's why I told you the pain neuroscience education is a critical thing.
Hmm.
If you know what is happening with the pain in the brain, what is happening or the connection between the knee and the brain, how it works, you have to make the right plan. So first stage, protect. If I'm passing all my stages, like I have a range of motion full, 130 degrees flexion, 0 extension, I'm okay. It's very easy. It's not like shoulder. It's more complicated here, okay? Then I'm starting to load this joint because I need to load it because
Yes.
I have a chronic patient maybe. uh, I have the problem of arthrogenic muscle inhibition, so I must trying to load, or I must use tools like muscular stimulation. Do you know what is that?
No, please explain.
Neuromuscular stimulation is a small device with current, so you activate your quad passively,
Okay.
or
Yeah. I think
you doing,
chiropractors do that, right? Chiropractors, I believe they
yeah,
do. They put the little things on there.
yeah, but I don't know why they do it,
Yeah, I
because
mean
you,
neither. Okay.
yeah,
Okay.
you, big, yeah, the chiropractors, big conversation again. So I can combine the actively contraction of my quad with the passively. I can do it together, or I can use BFR, blood flow restriction. Okay, this is totally unknown words, eh?
No, no, blood
Okay,
flow restriction. I'm following. Yeah.
we know that from the fitness industry.
Yes,
So
blood flow restriction. You're not
we're
allowing the
using it a
nutrients.
lot now. We have new devices with a lot of safety now, bigger safety, because we have problems with the previous devices. So I can use all these devices to activate my muscles, to load the joint, and that's why I'm starting then to reconditioning the stage of reconditioning. What means that you say to your patient, okay, you can walk today 2 kilometers, and then when you come back, tell me what is happening. Like, it's like a plan. That's why I told you the periodization is a plan. Then it's like you run for a marathon at at the start 5 kilometers, maybe the go to 10, to go to 42. Okay, it's the
Yep,
same thing.
correct.
So if I don't have effusion, pain, if the joint is not warm, it's not hot, I don't have inflammation, I'm going. Then we have two uh, groups of people. Some people say, George, I want only to walk with my husband to go for a trip. They don't need a lot of things. And some people, they say, I want to play tennis again. So we have a stage like return to play, as we say in sports medicine, or return to sports. But there, I have many factors that influence this stage. It's the same thing with the decision making when an athlete is injured. When I have the big problem with the muscle injuries, we have a lot of re-injuries. It's the re-injury rate is about 35%. 1 in 3, yeah. Why? Because I must have some factors to achieve before to play again. And now we have the knowledge and the research to step on them, to say, okay, in orthobiologics, the factors are small, they're few. But if I have a professional athlete and I'm doing to him for his muscle strain thread grade, okay, higher in the tendon, I'm doing him a PRP. After that, I have many stages to achieve before we have the return to play for him. If
Hmm.
I'm not doing it right, I have an injury.
Yeah. So it's pretty much saying like if you're doing too much too soon, it kills the gains.
Yeah. If you're doing that after orthobiologics, you will destroy the tissue. That's why I'm talking from the beginning about the plan, the plan, the plan. You must have a plan.
Okay. And do you think that your framework does it change depending on the biologic that is used? Meaning, if they use either pure P or bone marrow, does it
No,
matter?
I don't
No,
think,
right?
Oscar, I don't think so. I think that's why I told you. I think we must choose the right orthobiologics for the right cohort of people, not the right person. I don't think it's so personalized. You have a thing, you have a goal to achieve, okay? And I don't think you must protect more the bone marrow and less the PRP. The protection comes from the factors you have for the certain patient. Maybe he's 150 kilos, he's fat,
Yeah,
okay?
that's bad. Yeah.
If you are overweight, okay, you
And
must wait. So it's not about the bone marrow or PRP.
yeah. Yeah, and then not only yeah, so one, yes, he's obese. He's putting a lot of weight on his knees. Maybe his knees are bad, but usually their lifestyle is also not optimal. It's not good. So they're probably smokers or they're probably,
So
sedentary. So
that
that
means
adds to it, right?
if you are a smoker, that means your blood supply to the tissues are less. If you're not, if you're not, the sleep is a rehabilitation tool today. If you have a top quality sleep every day, that means when you're sleeping, you rehabilitate. Yeah. Okay. That's why I told you many factors,
Yeah,
and
many.
many factors, and the doctors. Okay, normally this is a product, and the companies they create the product, but the thing before and after, it's like a mess. It's like a what is happening? Why
Yeah,
we don't have a plan before? We don't have a. But if you are obese, you need a different rehabilitation plan.
yeah,
Okay.
yeah. You need to lose weight before, fix your lifestyle.
No, I'm not in this because some people maybe they have problem with the hormones or something like that. That means they cannot lose weight very easy. Okay, but if I'm strengthen their knees a lot, they can carry this weight around.
Good point. Great point.
Okay, that's why they tell me, okay, what is happening? I'm obese. What is happening with my low back or my knee? No, I don't care. I don't. I'm not a nutrition specialist. I don't care. I care to make you walk properly. That's why we see a lot of people because of the pain. They walk like a duck or protects the limb. Okay,
Yeah,
that's
yeah.
what. That's the first thing I'm doing to a patient after orthobiologics is gait lesson.
Would it explain that a little bit? Gait
Gait
lesson.
lesson means how to walk properly again.
So I know I saw because we do some trainings, and one of the doctors that I work with, he has a nice machine to where it's like a treadmill. It's a fancy treadmill, but then it has a big screen in the front, and he has the patients walk, and then the treadmill and the camera looks at its mechanical, how it
Right,
walks,
right.
how that.
Because
Yeah.
so the eyes, they are the windows of the brain.
Hmm.
So
The
if
eyes, you mean?
the eyes, yeah, the
Okay,
eyes,
the eyes are the
the
windows of the brain.
brain, yeah.
Okay.
So if I'm walking without using my eyes, that means the proprioception. The term means proper when my limb and my body is in space. When I'm injured or I have a hip arthrosis, the proprioception is affected. Okay? So these fancy treadmills, they combine the eyes, the vision, with walking. So I can see I'm not walking properly, so I'm fixing it. Because we say, okay, walk better.
What does that mean?
Yeah. I don't know how.
Yeah.
Eh?
Yeah.
But when he sees in this fancy treadmill, he can correct himself. That's why I told you the vision is crucial for the brain. Okay, that and we now I'm doing some lessons on the Queen Mary University London at the sports medicine specialty. That means you're a doctor in UK, and if you want to be a sports medicine doctor, you need 2 years for a master degree. So
Well, congratulations.
thank you. So
Yeah. Just adding more skills and more things on top of it, huh?
I explain to them that everything in life, the brain gets information from a neurological pyramid. At low, this is the proprioception. How the brain takes information from receptors we have around in muscles, joints, ligaments. This is proprio. The fitness trainers in gyms, they work a lot on proprioception. Why? They're doing exercises, squats, and everything. This is proprioception. The second thing is about balance. So
Yes.
we have a system in the ears that controls our body in around. And the third thing is the eyes. So those three things, the brain takes information like a pyramid. Okay? I'm explaining this because this is crucial for performance for athletes, and this is crucial for rehabilitation. If you're doing only proprioception, as you said, maybe I walk, but I walk like a duck. And then if I walk like a duck, the amount of pressure in my new tissue of bone marrow in my knee suffers. That's
Because you
why I
haven't
told
corrected
you
that.
we have many things to fix before the orthobiologics to become the golden standard. We must fix the before and the after. Cohorts, RCTs, like you said, which procedure is better for arthrosis grade 2. But I must have the same cohort with, same age, okay? Maybe same height, same BMI. I cannot compare an obese person with an athlete.
Mm-mm.
Okay?
Totally different. Yeah. Interesting. Eyes are the windows of the brain. I like that.
Yeah. Indeed, it is.
Yeah. Yeah. I
That's
like that. You
why
put that.
our rehabilitation, we do rehabilitation with vision perturbation. We do rehabilitation with noise perturbation. We put some headphones, but not in the eyes, here on the bone. So if you perturbate the brain with noise, and do you know what strobe goggles is? The strobe goggles, they're
No.
Google it. Strobe goggles is special goggles like electronic devices
Okay.
that perturbate the brain. So if
Dr.
they
Kakavas, what
close
do you
one
mean? What do you
eye
mean by
eyes,
perturbate? Sorry to cut you off. What do you mean by perturbate? What does that mean?
these glasses, perturbation is the term that I'm doing something hard for the other.
Okay. Okay.
Eh?
Interesting. Okay.
So if he walks with one eye closed, what is happening to the knee? To the same side knee and the contralateral knee. What is happening? Because when I have a problem, and it's a chronic one, the healthy leg is affected too.
Yes, it's true. Because you're compensating, going back to compensating and working over hard. So perturbating.
And the brain doing this thing by its own. Okay?
Yeah.
That's why after an ACL, we have many athletes with re-injury at the other ACL, to the other leg, the healthy one. 45% of re-injury.
Okay. Um, you've talked about different markers, and I agree with you to where, the rehab, from the injection to the outcome, is very important, and it's you need to make sure that that whole entire process is monitored properly. You have some markers, for example, that you talk about: strength, range of motion, exams, patient
Pain, of course.
reports. Yes. Which ones are the most valuable in your opinion from day to day?
No, it depends from the stage, Oscar. I think the first stage, you need to control the pain and the fusion.
Okay.
Because the fusion, if I have a fusion in the joint, that means water in the joint. This water creates pressure on my new orthobiological tissue, right?
Hmm.
So I have to dry this joint. So if the joint is dry from the fusion, I have a better range of motion. I have less pain because the knee is a sensory organ. We have many a great mechanism in the knee. It's a sensory organ. And it's connected straight into the brain. That's why we say when I have an ACL injury, we have a brain injury. Why? Because I'm putting a graft from my hamstrings, for example. I know that this graft in 4-5 months, it's live. It has a blood supply.
Yeah.
Okay, because it's from a different body region. Okay, but we don't know what is happening with the brain when it's like I'm putting in your computer a USB stick, but the computer cannot see it.
Yeah.
Can you imagine that?
Yeah. What is this? It's an external drive.
Yeah, yeah,
An
yeah. No,
external
or
body.
nothing. No,
Mhm. That's true.
I cannot read all the data from this. So if I have an external drive and I have a lot of data, maybe the brain can read 40% of the data, or 20, or 60. That's why we're talking about the rehabilitation in the future must have a neurological. Old days, we think the neurology was for strokes, was for people after a car accident with a spinal cord injury. But we know now that people with simple injuries, they need to have a neurologically rehab with a different philosophy.
Interesting. Golden. You've shared so much information. So, in early in the conversation, you mentioned the SaaS, that you're working on a digital monitoring software. Um, how does that connect with periodized rehab, measurable and scalable, what you're doing with your work?
No, if the SaaS, the SAMD, it's
What
a
to say?
tool
Oh, software as a medical device. That's what that
device,
means.
yeah. And now we have software as a medical device, AI powered.
Okay. Okay. Can you
Why?
talk? Yeah, yeah.
Because our ambition, because we build the product now, is to create a digital twin. Do you know what is digital twin?
Distal twin. So I'm saying far away. I know. Explain. I'm trying to get.
Okay. I take all the data for Oscar and I make a okay a digital representation of
Oh,
Oscar. So I give a digital
digital.
face.
Okay, gotcha. Digital
Hey,
twin. Yeah, my digital person. Got it.
yeah. So when I have your digital person, I can apply to him a different periodization.
From
And
my actual self.
yeah, but
Okay.
not on yourself, the risk is minimum. I applied this like a scenario to your digital twin.
Mhm.
And the digital twin says, oh, successful. Okay, I will do it on Oscar. Okay, this is the future. So if I have data from Oscar,
Yes.
my software as a medical device platform creates a digital twin. All my decision making is digital, so it's not like I say, okay, first week you do this, the second week you do this. No, all is driven by data.
Yeah.
So I
And
can apply to you the return to play criteria and say, okay, Oscar is not ready, so I don't have re-injury.
yeah.
That's
Where
why
are you?
I need. Now the digital twin, as you know, we have factories with digital twin. In aerospace, they do digital twin for aeroplanes, for turbines. So they have a turbine of an aeroplane and they make scenarios, different scenarios. What is happening with the temperature, with different things. So they know if I have these scenarios, I can solve them like that. That's why the digital twin is the future in not only sports medicine, in orthopedic medicine too, because it's a personalized medicine. The digital twin will tell me your question, which procedure to choose, the digital twin, because I have applied the bone marrow to Oscar, 70%. The PRP, 80%. The adipose fat, 95%. Oh, the adipose fat is for Oscar. Okay? This is
Yeah.
because you asked me before what to choose for a certain patient. Today, we don't know. Every doctor is choosing, a procedure, but where is the data? It's
Yeah.
a totally new world, my friend.
That sounds amazing. And then now
And
with
it's
AI and
exciting. Yeah.
everything. Yeah.
It's exciting.
Yeah, yeah, it is exciting, especially with AI now, how it's moving and so fast. That sounds. So where are you in that process regarding the software as a medical device? That what is it called?
The call is bespoke. That means the name is bespoke. So
Bespoke.
it's, yeah, bespoke. So it's like made to measure for everyone. That's why this is a personalized medicine. This is, the personalized medicine is they hope with the digital twins to create your own medicine
Yeah,
for you only. Okay, because now they're giving to big cohorts of people the same medicine, but some people they have contraindications, some people it does not work. Okay, with the personalized one, that's why I told you I can choose the right procedure and I will have the best outcomes.
yeah, yeah. That is one of the biggest, I would say, problems that I do see. Like, okay, you have all these different products.
But
Which one is
this
best?
is the problem with the big pharma, now. The big pharma, they giving the same medicine to a large amount of people, and they trying to control the contraindications, and they cannot control the outcomes. Okay,
Yeah. Uh, they may not be interested in the outcomes.
maybe, but I think the outcomes. That's why I'm telling to the orthopedic surgeons the outcome from your patient is your reputation,
It's
and
true.
this is okay. This is so. Uh, I explain to my patients that I cannot heal or make treatment to with outcomes 100%. But if I'm on 95%, I'm a very good doctor. So the less failure you have with your patient, you're a good doctor. But the failure is a multi factor thing. That's why I'm telling data-driven decision making before, for the procedure, and afterwards.
Yeah. So for example, let's say you have a patient that's in pain, right? And from your process, you want to do the prehab first and you want to set them up for success, right? How how would you manage a patient that is in pain and they want relief now? Like, how does that fall into your prehab program?
We using mechanotherapy. Mechanotherapy, what means? The pain, as I told you, is a mechanism for the brain because it feels threat.
Yes.
I'm explaining to my patients, you are like the car. When you turn on your car in the morning, you have a light there, maybe it's yellow or red. If it's yellow, you can go to the supermarket. If it's red, you must stop immediately and go to the mechanic. It's the pain is something like that. So I have pain with tissue damage, and I have like a functional pain without tissue damage. That's why I told you the pain education, to explain to the patient what type of pain they have. Maybe they have a mechanical pain. Maybe they have inflammation. Maybe they will have, I don't know. That's why I told you all this is a very broad thing with many factors involved to achieve the best outcome. That's why I don't like, okay, I did PRP and I'm not happy. You're not happy because you did a very good procedure. I'm always telling to my patients, I assume your orthopedic doctor is the best in the world. That means your surgery is the best. Your orthobiological treatment is the best. The difference is what happened before and afterwards. This is the difference. I assume the procedure is perfect.
Interesting. What what are the biggest gaps in that you see that comes after rehab in orthobiologic procedures? Like, what do you think is the biggest gaps that you see?
I told you them. I think the monitoring is the bit because
The what? The monitoring?
the monitoring of the patient. We need a constant monitoring of the patient, especially post surgery, because the surgeries are very expensive in US. Okay, I don't know how do they charge for an orthobiological treatment, but I know that the surgical treatment is very expensive. Okay, and the payers are the insurances. The insurance is the payer. That means with the bad outcome, the payer must pay for the same patient, new MRIs, new treatments, new orthobiologics, maybe a revision of the surgery, you see? So I have a system that, because, the people now, they will achieve, I think, 100 years old till 2035. I'm very optimistic about this. That means we will have a lot of people above 60 years old with orthopedic problems, spinal problems, hip and knee osteoarthritis problems, okay? This is age-related problems, right? That if I don't have good outcomes, the medical systems, the insurance systems, the state insurance systems, they collapse. This is like a
We're
financial nightmare,
yeah. Well, we are seeing, I mean, not, I wouldn't say a collapse, but we're seeing it right now with, the way what I'm seeing right now is that the younger generation, they're waking up. They don't want surgery. They want non-invasive. They're hearing about stem cells. They're asking the doctors about stem cells, about,
Of course,
no surgery.
of
Hmm?
course, who wants surgery?
Yeah,
But
no one.
as I told you, the orthobiologics is a breakthrough the last 10 years, but the thing around the orthobiologics does not work well.
And
That's
that is,
why
that is the
we did,
prehab.
this paper was a breakthrough about the periodization, because we have made periodization in tendinopathy, totally
Yeah,
different thing.
yeah.
Periodization for ACL, totally different thing. But the orthobiologics, because, it's a financial issue too, because, it's something now in US is thriving, okay? A lot of orthobiological treatments around, right?
Yes, a lot.
A lot, okay? If you do not have the plan, as we said before, the outcomes are bad. That means maybe in 5 years, this procedure will be lost because of the other factors, not because of the quality of the doctor or the quality of the tissue involved.
100%. I agree with you. It goes back to, that regenerative medicine does not have a product problem. It has a thinking problem.
A
Eh,
concept problem. You
yeah,
can say a concept problem.
a concept problem.
You need a concept. Yeah, you need a
Unpack that a little
concept
bit.
around. Yeah, you need a concept around this. It's not only I do injection, okay, everything is fine. Okay?
Yeah, and then that's what everyone. It's a transactional procedure. I feel like, they just want to get a PRP. They've heard great result. They've heard great stories from other people, from athletes, but yeah, I
But
understand.
Oscar, they have great stories, of course, but if I inject an athlete, the athlete have the capacity because he's very trained.
Yeah,
Eh?
that's true too.
He has like the muscle
He has the
memory
resource. He has the
to
resources,
restore
everything.
faster. But I
Yeah.
think the orthobiological is a tool for older people. It makes their life better,
Hmm.
quality of life better.
Yeah.
Okay.
So interesting. So would you, from your experience, because you deal with athletes and patients, right? Average people, do you see a difference in outcomes from athletes versus an average person?
Of course. I told
What
you
are those
the
outcomes?
athlete, the athlete, the athlete is in different states.
Yeah.
The
Do you
athlete,
see better outcomes for them? Because, like I
of
said, they have better
course,
resources.
of course,
Interesting.
but the athlete has the complexity. What means complexity? I must know, regardless of what treatment did the return to play time.
Yes.
As I
Yeah.
told you, The lay people, no. The lay people, I'm not in pain. My knee is not hot. I'm not in inflammation.
Yeah.
I don't have effusion. Okay, I will go for a walk. So it feels the treatment helped him a lot. The athlete is, especially the elite athletes, it's a totally different thing. If you don't meet the criteria for return to play,
Yeah.
which are many, we have a consensus on that from a Bern conference. So there are around 12, the criteria to return to play, okay? So if I don't meet the criteria, I don't care what orthobiological treatment did. I have to meet the criteria. I have to, the LSI, the leg symmetry index, to be 90 to 95%, the one leg to the other. If it's not, I will have an injury. It's a totally different thing, the elite athlete.
Yeah. So do you, because they have, higher expectations, do you see better results in athletes versus
No,
the
no, no,
average
no. It's not
people?
about high expectations. It's about the capacity they build through the rehab.
Okay. I see
The
what you're
the
saying.
lay people, they have minimum. They need the minimum outcomes to have a quality life.
I see
But
what you're
an
saying.
elite athlete with a tendon problem, patella tendon problem, a basketball player, okay, they need the best outcome because they play 3 or 4 games per week. They travel around. That means when I'm traveling around, the pressure in the plane does not help my orthobiological treatment.
Hmm.
You see how many factors?
Yeah. Yeah.
I don't sleep. My circadian clock, do you know what circadian clock is? It's we have an inner clock. When outside is darkness, maybe I wake up. Why? Well, I have an inner clock.
Yeah. Okay. Got it.
The inner clock helps on my rehabilitation and recovery. So all these, you see how many factors. That's why the factors are many, and I must meet the criteria for all these factors for an elite athlete. Lay people, it's very easy. You control, as I say, the things, you plan them, you go after them to everyday activities, it's done.
Okay. So if you can send one message to every clinician performing orthobiologics injections procedures about what happens after the injection, what would it be? What would it be, that one message that you have to those orthopedic doctors doing injections?
No, I think we must have a consensus. Consensus means we meet people from the orthopedic community and rehabilitation community and maybe the performance community because of the elite athletes to set up criteria for pre-requirements of the orthobiological treatment and post. Because now it's like something like, I don't know, it's foggy. You don't know? It's foggy. And when it's foggy, I cannot see clear the outcomes.
Yes.
So we need a consensus. Consensus means the same thing we do now for the ACL. That means it's a group, they prepare questions for the clinicians, but the questions are from the research, okay? And they say, do you agree on this? Do you agree on this? Do you disagree? Do you strongly disagree?
Yeah.
And this is like a vote. So if the votes are positive, we have a consensus like we need a full range of motion before an elite athlete goes again for return to play. Eh?
Yeah.
We don't have a consensus on that.
Hmm. Okay. So we need to build that.
Yeah. This is the message for our today conversation.
Okay. Thank you for that. So you mentioned that you have a research paper about the periodization.
I
Any
have
other you
many.
have many,
I
yeah.
have many. So but the periodization in different conditions. Okay.
Okay, got it. So if you have many of them, where can we find your work and follow you so we can learn more about you, about everything that
Okay.
you're doing?
I think I publish a lot on on LinkedIn. I have almost 46,000 followers from around the world.
Yes.
And my you can find the information on my ResearchGate. ResearchGate is like a library with every researcher and clinician has all his work there. It's free to, so you can read there whatever you need. But okay, we're moving forward with this. You know, it's the hardest thing. It's to be a clinician and researcher because you work with patients, you talk to podcasts, you make lectures to conferences, and you work on research too. This is very hard because the clinicians, they are strongly clinicians. They work in hospital clinics, you know, and the researchers are university professors.
Okay.
They do not involved in the everyday life of a patient. Okay,
Yes.
that's why
Okay.
it's hard. Okay, but I
Yeah.
like it.
Yeah. Yeah. But you're the good thing is that you're getting every stage and every level. You're working with the patients. You're working on an academia.
Of course,
You.
that's why we keeping data many years. That's why I told you I'm obsessed with data. So
Yeah.
we keeping data many years. So we're using this data for new research, okay? But because without data you cannot do research. So
That's true.
it depends what you do, but we need, as I told you before, a big randomized control trials to compare different rehabs. Okay, I have a PRP, but I'm doing different rehab. I have different outcomes. In a different randomized control trial, I compare different orthobiological treatments. I have a cohort of patients with PRP, cohort of patients with bone marrow. With the same rehab, what outcomes are the best? Which one?
What was the
We need
pre?
a lot of work on this. Yeah.
Yeah, yeah, yeah. I've seen a lot because I follow you on LinkedIn and I've been very vocal on LinkedIn too. And that's one thing that I do see that we do that the trials need to be better structured. They're poorly done. I would say that's what I've been reading a lot on. So what would be the ideal structure of a research for you to say like, okay, this was a
You see,
very
I
good.
think we have two types of research, or two types. It's okay. It's a broad thing. We have the CROs. The CROs is clinical trials they are doing by the pharma companies. Okay, this is CROs. They are very strict thing, expensive thing, because when I have a pharma company that create PRP products with growth factors, for example, before it goes out to the market, they must test it.
Yes.
This is CRO.
Hmm.
And we have the research we do in the universities or organizations. We have a lot of research the last 5, 8 years, many papers, thousands of papers, but I don't think they have the good quality.
That's what I meant.
Yeah, they don't, because you know this is a, I think, $1 billion market. The research now, I think it's 2 billion. So
just growing.
a lot of people, they want on their CV to have research. We have a lot of predator journals with very low quality, eh? And you read very bad papers. That's why you cannot find a lot of RCTs.
Yeah.
It's hard to find.
Yeah. And good ones.
Yeah,
Yeah.
good
Okay.
ones with
Yeah.
big cohorts, okay, or with different sex. What is happening between women and men?
True.
Eh?
Yeah.
Different hormones, different. The anatomy is different. The quality of the musculature is different. That's why.
Yeah.
Okay.
Yeah. Beautiful. So people can follow your work on LinkedIn. Any other, you have
And
a website,
The ResearchGate
ResearchGate.
is the research library of
Yep.
the library of the researcher. ResearchGate, yeah. I think the LinkedIn. I don't like TikTok, Instagram. I have a Facebook account because I like to read opinion on Facebook
Yeah.
mostly.
Yeah.
But okay, no. I think the LinkedIn is the best tool.
Yeah. I agree, especially to, meet with professionals and scientists and
Yeah,
doctors like yourself. So
and connection between professionals.
100% and share what everyone is doing around the world. So beautiful. Well, Dr. Kakavas, thank you so much for your time. It was
Thank
a
you very much,
pleasure.
Oscar. Thank you for the invitation. Okay, we'll be in
No
touch.
problem.
Thank
Yes,
you.
sir. You have a good one. Have a
Bye
good day.
bye.
Adios.